Hello, my name is Catherine Lopez, and we're going to be presenting on the Bear Below the Elbows campaign. The objective is throughout the presentation, the reader is going to gain an understanding of the identified clinical problem, which we'll discuss. There's going to be an emphasis upon utilizing shared governance to support cultural change and support evidence-based practice. We'll go over methods of disseminating research and quality outcomes, and then go over publishing and the ability to influence health policy or change within the hospital. So the clinical problem that we looked into, the Bear Below the Elbows campaign, the question is, in pediatric intensive care units, the PICU, in our patients up to 22 years in age, how does bear below the elbows compared to clothing and or jewelry below the elbows affect hospital-acquired infection rates? So to look at this in a evidence-based practice way, we did research on 6 different articles, which we'll cover each article in depth. So the first article that we covered is Hospital Infection Control Bear Below the Elbow and Implications for Infection Control. This article was case series and reports, and the purpose was to see if there was indeed transmission of pathogens between the healthcare worker's clothing and the patient. The research showed that there is conclusive evidence shown by numerous studies that clothing worn by healthcare workers can be contaminated with clinically important bacteria and fungi. And there are 3 essential criteria to implement evidence-based practice within our hospital setting, which is potential for benefit, there's no risk for harm to our patients, and that there's minimal cost, and which Bear Below the Elbows campaign fulfills all 3 of those criteria. The second article that we looked at was bacterial contamination of healthcare workers' white coats. It was a randomized controlled trial. 149 participants were assigned to a control or an experimental group. The purpose was to see if those who wore white coats were a vector for patient-to-patient transmission of bacteria or fungus, specifically the S. aureus. In the study, each participant participated in a anonymous survey, and then each coat was anonymously cultured in the significant places where it is most likely that a clinician to patient contact would occur, such as the cuffs, like neckties, the sleeve areas on the forearms. And the results did show that 34%, which is 23%, were contaminated with S. aureus, and 6, which is 18%, were MRSA. Article 3 that we looked into was Bear Below the Elbows, a randomized trial. It was a randomized control trial of 20 randomly selected individuals. The purpose was to see if the physician's coats, again, were vectors for bacteria and fungi because they are seldomly cleaned. In this study, the participants were randomized to wear short sleeves and long sleeves, and then they examined a contaminated mannequin versus an uncontaminated mannequin. And then the coats were analyzed for bacterial contamination to see if there was transmission from contaminated to uncontaminated. In the trial, 20% of instances of sleeves and or wrist contamination, the DNA marker was transferred to the second mannequin. In the fourth article, Bear Below the Elbows, Common Sense or Nonsense, it was just case series and reports. The purpose was to see if transmission of pathogens is based on the awareness of patient's skin and surrounding environment are contaminated with pathogens. The research showed that some pathogens and some type of fabrics have persistence of these organisms, and that they can live for a long time, such as the Staph aureus, which can live up to a month, and the Enterococcus facialis, which is up to 3 months. The results did show that more evidence needs to be conducted to conclude if bare below evidence is a practice that truly makes a difference in infection rates. But in the European studies, such as in the UK, and studies in Australia, showed that there was a decrease in hospital-acquired infections. In Article 5, bare below the elbows fact sheet, it was case series and reports. The purpose was put out by the World Health Organization, who recommend that long sleeves to be avoided. Long sleeves have been found to be contaminated with pathogens and can impede appropriate hand hygiene. Essentially, this is why we have contact precautions, why we don appropriate wear when we're going into a contaminated room. The research showed, for example, rings are associated with Staphylococcus aureus, gram-negative bacilli, or Candida species. And the white coats may be an important vector for patient-to-patient transmission of S. aureus. So the results implicate that bare below elbows should be followed by all staff in clinical areas who are having direct contact with patients and patient care. And the last article, Article 6, was bare below the elbows, a randomized trial to determine if wearing short-sleeved coats reduces the risk for pathogen transmission. Again, it was a randomized controlled trial of 20 randomly selected individuals. The purpose was to identify if there was a connection between the sleeve length versus transmission. The study measured how many times a clinician's sleeve would come into contact with a mosaic pathogen, which was on a contaminated mannequin, similar to the previous article that we discussed. The results showed that 5 out of the 20, which is 25%, had contaminated pathogen on their sleeves, and it transferred to the second patient mannequin. So strategic planning. The plan would be to design a study and have recommendations that can be identifiable benefits and risks to patients. It's going to show that it's a group decision, it's relevant to the practice, it's feasible, appropriate, meaningful, and effective to our practice. So in case of bare below the elbow campaign, the strategic plan would be no long sleeves jackets, watches, rings, jewelry such as bracelet or rings, or artificial nails. How to put this into operation would be a pilot program, which is not a widespread change. So we would start it in the PICU specifically, and if we have successful results, then transition it out into the other units. The theoretical model would be the Iowa model. This provides guidance for nurses and other clinicians in making decisions about clinical and administrative practices that affect patient outcomes, which incorporates 7 components, as you can see here. The most important component for overcoming barriers is forming a team. The team should be anyone that's invested within this campaign. So for this team, it would be all our PCTs, our nurses, our nurse managers, our intensivists and specialists, respiratory therapists, child life specialists, and volunteers. So internal evidence, a way to see if the initiative is useful, meaningful, something that is feasible into incorporating into our practice. would be things such as surveys, patient satisfaction surveys, qualitative research, and worker and patient opinions. And then the evaluation. So evaluation is to audit feedback through the process of implementation, which is conducted. It highlights the program's impact, and consistency can only be assessed against the actual change occurring. So in the case of the Bare Below the Elbows campaign, we would evaluate the goal in each department, in this case the PICU, utilize the audits and feedback to find where the deficits are or where the problems lie, and then continually utilize these tools to improve quality care. So find the problem, fix it, put new practice into change, find the problem, fix it, etc. And then these are just the references that were used. And thank you. Any questions?